I work with the heart, this magnificent organ that from about the 12th week of gestation is ready to nurture us, to let us grow, live, love, have all our experiences in life. And it does so over 3 billion times in a lifetime, as an average, most of the times without giving us any trouble, without even reminding us of its very existence. Unfortunately, this is not always the case. Close to 1 in every 100 children born may present with a heart problem. People like myself work in diagnosing or identifying and treating these children. Now, some of the conditions that we find are simple and easy to treat, but others can be very complex. These slides are not here to shock you, but rather to illustrate some of the steps that a baby born with a major congenital heart disease may have to undergo, and to give you the perspective of what we, pediatric cardiologists, are faced with in our everyday life. Now, in countries like ours, in regions like ours, we are faced with major contrasts, like this little boy who has a major congenital heart lesion, but is doing very well in the post-operative phase and was soon back with his parents, and the little girl with the same disease, but who presented nearly 2 months later and had a much harsher post-operative period with complications that were much more related to her malnutrition than her heart problem. This is the reality we're faced with on our everyday life, and it really is not easy to orchestrate all the steps necessary to care for these children. We believe that where there is a will, there is a way, but it's really hard to put on this big orchestra when sometimes you may not have the musicians or the instruments may be lacking. And we are also faced with another challenge, which is the fact that we live in a globalized world. And that means that for every problem, there is a preset solution. Now, sometimes it may work perfectly well, the problem and the solution may fit, but sometimes the problem may be very small and the solution won't fit as well, or the problem may be very big and there will be a tiny little solution. As we know, most of the times the solutions are brought from outside, and those who design them may not have experienced the problems, they may not know the local conditions. That's why we ask, and what if we could do different? What if we could identify local talents, choose our own music, and put together an orchestra that may not be the most perfect one, but that may be the one that fits our goals? We call it Legos, and that's the experience I want to share with you. Legos is an acronym for Lead by Empowering Groups to Optimize Solutions. And the basic idea is that when faced with a problem, first of all, group those related to that problem and try to design a solution together, understanding what the problem is, what they want as a result, and then move on to empower people to achieve their result. And empowering can be human resources, economical resources, but certainly and most of all, it's related to knowledge, to changing the culture, to getting people to understand that they matter, that they involve, that they can make the difference, they can change their own situation. Then lead by showing how it can be done, and you may actually end up finding different solutions from what you imagined in the beginning. Work model is plastic, it's adaptable to different realities. I want to share with you an experience that has been taking place between Pernambuco and Paraíba, two states here in northeast Brazil, since October 2011. Paraíba has close to 4 million people. Many of them live in rural areas and a lot of poverty. They didn't have a structured care for congenital heart disease, like many places in Brazil and in developing countries. And our challenge was to work with the health secretary to orchestrate services from screening to diagnosis, clinical, surgical, and post-operative care for these children in that state. Not an easy task, but the first step was to sit, talk with local people, and to establish a network so that we could group them and make sure that they would communicate. We developed a web-based system and acquired and distributed equipment, simple equipment like tablets, which were distributed to the major maternities in the state. The next stage was the development of the network's protocols. Some were general ones that discussed the model of the network, and we tried to spread them as much as we could. Then we moved on to specific protocols We asked the pediatricians to focus on the cardiovascular system, listening to the baby's heart, feeling pulses, the nurses checking on the pulse oximetry test. And for those babies who failed this initial test, or this level 1 screening as we call it, we trained the pediatricians to be able to acquire heart images on an ultrasound on the bedside and formed a group of pediatric cardiologists who were on call on a 24/7 basis to be able to review those images, discuss with the local physicians, and after the initial training, most of the activities were conducted via telemedicine. One hospital was set up to be the central for pediatric cardiology, and our team would travel once a week to perform operations while training local teams as well. In doing so, we try to structure the health system to use professionals that are available at the bedside, like nurses and local pediatricians, to start the whole process, then go on to pediatricians trained in echoes, and then the cardiologists, and eventually the heart surgeons. And together they have screened close to 200,000. And together they've screened close to 200,000 babies in the 6-year period, suspected a heart condition in 2 of every 100 children seen, and confirmed it in 1. This screening process moved the state from levels of detections that were close to the African continent to screening levels very close to what we see now in the developing world. But then we faced our first challenge, which was how to detect the cases of congenital heart disease in older children. And the first Legos model adaptation was to devise an active search for these children, and it was called the Heart Caravans. It started on the 2nd year of the project and has grown quite a lot, from 36 professionals to over 100 this year, seeing 500 patients, being over 2,000 patients, and started with cardiology, now involves a number of specialties, and also does a lot of training and teaching during the days that we are on the road. It's a very charismatic action. Many people that have been in touch with it believe that it's the whole project. We gather families, the heart families as we call them. We teach health concepts using music. It's really hard to describe the whole intensity of the process, but a very rewarding one, undoubtedly. Now, the caravan uncovered another problem. We started finding these children, but they had difficulty reaching us. At the time, we had only 3 virtual outpatient clinics in the state, so we decided to open up another 12 rooms. We call them the heart rooms, 1 in each one of the towns that we go through with the caravan. It would be expensive to equip them with full cardiology equipment. It'd probably not really necessary, as there weren't those many children. So we trained local pediatricians and nurses to be able to run an outpatient clinics with us, and then decided to buy equipment, echo machines, portable echo machines, and everything else that's required to do an outpatient clinics. We call it the echo taxis, and there are 3 of them, and on the first week of the month they go to one place, and then the second week in another 3 places, third and fourth, in such a way that in 4 weeks they run 12 new outpatient clinics in the state. We do halters and things that had never been done before in the rural areas of Paraíba. We run a continuous health educational project, and about 2 years into the network, we realized the need to expand it from cardiology to full perinatology. So now we have a team that trains people how to see, diagnose, and care for a child. Important things like transport, for instance, which is a cause of deterioration, have been approached in these training sessions. Further down the road, we were faced with another challenge, the microcephaly epidemics, and again the network could help by using the same model and helping people to screen and follow up babies locally. We continue to provide support for these children through multidisciplinary outpatient clinics that have been run since 2016. Now we're approaching 6 years, and I could tell you a lot more. We're getting close to 200,000 patients seen. There are many other activities taking place, but I will just slightly change the approach and tell you about something that happened this Sunday while I was thinking about what to bring to this presentation. Now, the messages are naturally unidentified. We have specific telecommunication software, which we run during the weekdays and week hours, but we can't compete with some of the commercial ones. And this is a Sunday morning, so there it is. And the message comes from a nurse that says, I have a very sick child here, and she lives in a small town about 270 miles away from the capital of the state. That message was sent at 9 a.m. There is always one pediatrician and one cardiologist online, and they started guiding local management while checking if we knew the child, which indeed we had. She had had a major heart operation, had had also a gastrostomy, and as these messages show, in a matter of 1 hour, there were more than 6 colleagues involved, not just the 2 ones that were on call, but many others that knew the child from previous time in the hospital. They knew the child was the daughter of another child. The mother was 14 years old. They had major social issues that had also been addressed, and basically everyone started getting together, each one giving support and helping. And the major message here is that within 3 hours, you see now it's 12 o'clock, a lot of people had been involved, and the child had already been transferred to a major pediatric hospital in the capital. She had been optimized locally, an ambulance had been arranged, and all the steps necessary to give the child the best chance of survival had been taken. Now, for some people, this may not mean much, as this is obviously what should have been done, this is what the child deserves. But for people like myself who live and work in this part of the world, we know how much it means. People ask sometimes, how was this done? Is this experience reproducible? Can we do it again? Can we help? Can we put people together? And I truly believe, yes, we can. Material resources are needed, but certainly it's much more a matter of human resources, of getting people motivated, of rather than putting major computers in series, putting major brains in series, motivated, enthusiastic, focused to help human beings. LEGOS is an acronym for Lead by Empowering Groups to Optimize Solutions, but I think it's better described as Let Empathy Guide Our Solutions. I believe that respecting and valuing every member of your team, listening to everyone, allowing for adjustments to be made, that perhaps is the secret of really getting people motivated and willing to make a change and willing to work together. We know that one size does not fit all, and we need to open up for this. So hopefully we from the Orchestra of the Heart may have planted a seed in your hearts, and when you are next faced with a problem, you may consider Legolizing rather than globalizing its solution. You may be surprised with what you find. So I will finish by asking permission to say that yes, where there is a will, there is a way, but with empathy, where there is a will, there lies the best of the ways. Thank you.